Hello, my name is Sara Cohen. I am a DNP candidate with Maryville University, and I'm going to be talking to you today about nursing education to improve outcomes of medical patients with serious mental illness. My DNP committee consists of my committee chair, which is Dr. Boniface Stegman, and my second reader is Dr. Maria Snell. So it's important to know that there are 11.2 million American adults living with serious mental illness, as was a statistic in 2017. 46% of these patients with serious mental illness have at least one chronic comorbid medical diagnosis and often have more complex treatment needs based on the fact that they don't access care in the same way that individuals without serious mental illness do. Patients who have serious mental illness are often admitted to medical units because they also have medical needs, and they have longer lengths of stay and worse outcome than those patients who do not have a serious mental illness diagnosis. And it's very apparent and common for staff on medical units to not be trained or prepared to care for patients with serious mental illness. So there's many reasons why it is more difficult to care for patients with serious mental illness in a medical unit. Literature confirms that staff, in specifically nursing, often feel unprepared and uneasy when caring for patients with comorbid diagnoses of serious mental illness. Some reports indicate that the nurses describe fear, discomfort, uncertainty, and others indicate significant negative bias towards individuals with serious mental illness. The attitudes of medical staff tend to originate from gaps in health literacy, negative personal experiences with people who have serious mental illness, cultural and community attitudes, and lack of confidence in their ability to appropriately care for these patients. In addition, the environment on a medical unit is not ideal for caring for patients with serious mental illness. These units tend to be unlocked. There is a risk of elopement. Patients have access to unsafe equipment, and there's many ligature risks, which poses a hazard for both staff and patients. Nurses are consistently regarded as an irreplaceable part of the healthcare team, and they tend to the physical and emotional needs of patients and their families. Additionally, nurses typically spend more time providing direct care to patients than other provider groups. They are skilled at advocating for their patients' needs and excel at providing person-centered care to their patients. And they recognize that no two patients have the same healthcare needs. When it comes to caring for patients with serious mental illness comorbid diagnosis, medical nurses report feelings of fear, anxiety, and uncertainty, also some frustration. They also disclose assumptions that they have related to the behaviors of patients with serious mental illness, the inability to feel empathy for these patients, and tendencies towards avoiding the patients whenever possible. Considering the importance of nursing care for patients who are admitted to the hospital, avoidance behaviors, stigma-driven perceptions, and lack of empathy have a negative impact on the outcomes of these patients. So implementing a comprehensive education initiative to destigmatize patients with these comorbidities, enhance nursing knowledge about the neurologic disease process related to psychiatric illnesses, and improving the comfort that nurses have while caring for these patients will improve staff satisfaction as well as patient outcomes. The goal of this project was to improve the knowledge, skills, and attitudes necessary to properly care for patients with medical needs and comorbid serious mental illness diagnosis, and improve the care that nursing staff provides to patients with serious mental illness. Additionally, we hope to improve the experience for patients and improve the overall comfort level and job satisfaction of the recipients of this education. We do know that quality nursing care for patients admitted to the hospital is vital to ensuring good outcomes. So avoidance behaviors, stigma-driven perceptions, they do have a negative impact on the outcomes of these patients. So this education is aimed at destigmatizing patients, enhancing nursing knowledge, and improving the satisfaction of staff who are caring for these patients. In order to review the literature to see what has already been known or contributed to this body of knowledge, the PICO question was used was when patients with significant behavioral health diagnoses are admitted to the hospital for medical care, do they have fewer escalation events when cared for by staff trained in behavioral health management compared to being cared for by staff not trained in this? 9 of the 11 included articles in this literature review include the themes of stigma, including how it develops, how it affects the outcomes of patients with serious mental illness, and how widespread it is in the medical profession. Stigma is a widely documented phenomenon towards mental illness in the general population, and there are similar patterns in health professionals who are not familiar with caring for this patient populations. Medical professionals who do not specialize in psychiatric mental health care lack the appropriate training to care for patients with serious mental illness. Additional themes of skills, patient outcomes, roles, and proposed interventions were found. Training deficiencies exist in the initial undergraduate education and continue to lack in ongoing professional development. The specific required skills to care for this patient population include knowledge, training, communication techniques, understanding, and empathy. The term escalate is an important part of the PICO question that informed this literature search, and there was only one article that specifically mentioned this term as an outcome in the patient population. Improving patient outcomes is at the heart of why we study the care provided to varying patient populations and implement quality improvement projects like this. The specific patient outcome for this project is fewer escalation events in patients with medical and serious mental illness needs. Patient outcomes are linked to the training and skills of the medical professionals caring for them and to having access to appropriate medical and mental health care. We do know that patients with serious mental illness have overall poorer outcomes and higher mortality rates compared to the general population. There are many roles to consider when thinking about the care providers who may encounter patients with patients with serious mental illness in the medical setting. 8 of the 11 articles for this paper that were reviewed identified the specific roles or credentials of the care providers, ranging from doctors to advanced practice providers to RNs and even student nurses. In the literature, the interventions that were found most helpful were those that created attitudinal change and promoted therapeutic relationship building between providers and patients with serious mental illness. Education and increased exposure to this patient population, they found promoted familiarity and a better understanding for those responsible for their medical care. Some gaps noted in the literature were a lack of defined patient outcomes that were addressed in each study, and the inability to generalize findings among many of the studies. Limitations that were found include small sample sizes, geographical location of the studied interventions, and lack of comparison groups. The theoretical framework used for this project was the modified labeling theory by Bruce Link, who first described it in 1989. The modified labeling theory was an extension of the original labeling theory described by Thomas Scheff in 1966. Scheff's original labeling theory purported that once an individual is given a label of a mental illness, that label then exacerbates and drives the behaviors of the person. Essentially, the person becomes their label. Link described this modified labeling theory as his modified labeling theory as the stages that occur in the process of labeling, including how the label drives societal stigma and stereotypes. He describes the components of stigma that lead to discrimination and difference in treating based on the labeling, as well as recognition of a difference in personality or behavior, stereotyping, associating the difference with negative concepts, separating us versus them, and discrimination. Link suggests that it is necessary to better understand the effects of labeling and stigma on individuals with mental illness and how that affects their overall outcomes. This project began with a needs assessment conducted in a large academic medical center in the Northeast United States. For the purposes of defining serious mental illness, it was defined as individuals with schizophrenia, major depressive disorder, substance use disorder, bipolar disorder, borderline personality disorder, or intermittent explosive disorder. Patients could have one or more of these diagnoses. And the needs assessment showed that there was an increase in patients admitted with medical needs and comorbid serious mental illness over the years. Additionally, there is no formal training for medical nurses about the care of patients with serious mental illness. And there was an increase in escalation events year over year. An escalation event is defined as any time a patient threatens staff, becomes verbally or physically aggressive, refuses medical treatment that is necessary, or leaves against medical advice. So this project, the design of the project, it is a quality improvement project. It was exempt from the IRB. Quantitative nominal data was collected using the electronic health record. It was a retrospective chart review. The minimum sample size to determine significance, statistical significance, was 308, which was 154 pre-intervention and 154 post-intervention. The sample size that was achieved was 450 total data points. 225 were pre-intervention and 225 were post-intervention. Inclusion criteria for this project: patients were greater than 18 years old, had a diagnosis of one or more serious mental illness, those that were previously mentioned. They were admitted to the study unit within the study period, whether it was pre or post intervention, and they were admitted to the unit where the intervention was implemented. The exclusion criteria includes patients who are younger than 18, who are 18 years old or younger. They have no diagnosis of serious mental illness, and they were admitted to the study unit less than 6 hours. So for the intervention itself, the researcher created a multimodal education bundle. There were a total of 5 recorded modules and 2 scholarly articles. Within the modules, there were videos, voiceover presentations, and case studies. And these modules address knowledge, skills, and attitudes that the nurses were found to be lacking. It was self-paced learning, so the nurses were able to do it at their own pace and took approximately 5 hours. There was also pre- and post-learning surveys to gather information about their satisfaction with the information, as well as to ensure that they did complete the entire, all of the 5 modules. There were 5 nurses who participated. All of these nurses were employed on the study unit. 3 of them were day shift and 2 of them were night shift. Each of these nurses were paid for 5 hours of time from their nurse manager, and they were awarded 5 continuing education credits upon completion of the modules. So the dependent variable for this project was whether there was an escalation event, yes or no, for each 6-hour block of time. The independent variable was whether it was pre or post intervention. Nominal data was collected, so it was either yes, there was an escalation, or no, there was not an escalation. The sample size, as mentioned earlier, was 225 pre-intervention and 225 post-intervention. The statistical test that was used was a z-test of 2 proportions, and it involved retrospective chart reviews pre and post-intervention. This slide shows you the data input for the lower tail z-test for the difference of 2 proportions, as well as the final calculations for the z-test. The data for this study that was collected was not sufficient to show statistical significance that would indicate that the decrease in escalation events was a result of the intervention. The challenge in studying escalation events in this particular unit is that they occur infrequently, although more frequently in patients with serious mental illness than those without. When they do occur, however, they are high-risk situations for both patients and staff, and there was a decrease in overall escalation events post-intervention. The intervention for this study aimed to provide staff with knowledge about the various serious mental illness diagnoses encountered on the unit, while also providing personal and humanistic perspectives to help them grow empathy and understanding for this patient population. This type of education was not previously available to staff, and this approach had not been tried at this hospital. The intervention was developed to include didactic knowledge of serious mental illness diagnoses, as well as some techniques to evoke emotion and empathy. There were fewer escalation events per sample size after the intervention. Although this difference was not found to be statistically significant, the nurses who completed the education bundle all reported the education to be helpful to their practice and reported increased comfort in caring for patients with serious mental illness after completing the education. Throughout this project, there were no notable problems, failures, or additional costs identified by the researcher. The education bundle was modified to fit within a 5-hour time frame and to ensure staff were not directly interacting with patients who were on the behavioral health units. There was no missing data. The facility where this project was implemented provided additional support for the project by creating an online portal for the storage of the presentations, the articles, and the surveys. Initially, the researcher found that recruiting nurses to participate in the training was challenging, and the researcher really had to market the opportunity using a variety of methods before finding some successful techniques for recruiting participants. The strengths of this project include the design, participants, education format, and data collection. Retrospective chart review is an effective design for determining the effectiveness of an intervention, such as an education bundle. The RNs who participated in the study were self-motivated to complete the education, and all 5 completed the entire bundle. The education was available electronically to the nurses and was divided into 5 modules. The modules were comprehensive and were designed to appeal to visual and auditory learners. The nurses had ample time to complete the education and received clear instructions for receiving pay for their time and the continuing education credits. The data collected was completed by one individual, the researcher, manually due to lack of appropriate EHR, electronic health record reports, and it was completed in the same manner both pre and post intervention. The data collected was nominal and included no identifiable patient information. This project did have some limitations for consideration. The data collected for the project was based on a significant event note that was placed in the patient's chart. Some escalation events pre or post intervention could have been missed if the nurse caring for a patient with serious mental illness did not accurately document the escalation event. There is also variability to what constitutes an escalation event among individual nurses, also potentially skewing the data towards fewer events documented pre and post intervention. Additionally, the researcher did not collect any data to provide descriptive statistics for the discussion of the project. Another limitation to the study is the overall low rate of escalation events, as mentioned previously, on the study unit. There were fewer events post-intervention, and any reduction in escalation events improves staff and patient well-being. The low rate of events overall made it challenging to show statistical significance that the intervention lowered the escalation rate on that unit. So as mentioned previously, the researcher did not gather any additional information about the patients to complete descriptive statistical analysis of the study population in order to remain as an exempt study through the IRB. Having descriptive statistics to better understand patterns or connections between the patient population and the study results is a missed opportunity and should be considered for future retrospective pre- and post-intervention studies. Data like age, gender, specific serious mental illness diagnosis, time of day, and nurse-patient ratio would be helpful information to better understand patterns and relationships between the intervention and the outcomes. This project does have some limitations for consideration. The data collected for this project is based on a significant event note. Additionally, some escalation events pre or post intervention could have been missed if the RN caring for the patient did not accurately document the events. Another limitation to the study is the low rate of escalation events, and there are fewer events post-intervention, which is really an important thing to consider, so the clinical significance of this study is clear. For a study to be generalizable, the results are applicable to a broader group of people beyond those involved in the study. So for this study, we found that it is useful in this intervention could be useful in other acute care units within the study hospital, as well as other hospitals throughout the United States. The education content is not based on specific policies or processes and is relevant to novice through experienced nurses. Additionally, it could be adapted to a multidisciplinary audience. In order to sustain the results, you would need to increase the number of staff who are trained, expand the education to include all units where patients with serious mental illness are cared for, provide an annual refresher training for all staff, include this training in the onboarding and orientation, and send reinforced messaging at regular intervals. It is really important that we work to remove barriers to integrated medical and mental health care, including payment structures and co-location billing limitations. It could help to incentivize integrated care and encourage whole person care through bundled insurance coverage. And we need to reform healthcare policies to really support integrated care better. In conclusion, the study found a clinically significant reduction in escalation events post-intervention. The education that was developed addressed knowledge, skills, and attitudes and promoted the building of therapeutic relationships with patients with serious mental illness. There was no statistical significance, but that does not render the project or the results useless. We do know that the population of patients with comorbid serious mental illness continues to grow, and nurses and other staff do require education and re-education on holistic ways to approach the care of patients with serious mental illness. This not only improves staff and patient safety, but also patient outcomes. I am happy to answer any questions you may have, and thank you for your time and attention. These are some of my resources, and these are the rest of my resources. Thank you so much.